Good afternoon, everybody. I'd like to welcome you to the next session of our APDR National Virtual Noon Conference. My name is Dr. Hart Beatty. I chair the Education Committee for the APDR, and I'm also the Neuroradiology Fellowship Director at Boston Medical Center. I'd like to welcome two amazing speakers again today for our series, and we're so grateful for them taking the time to give the talks. A couple housekeeping items that we always go through. I'd like to remind everybody that the webinar is being recorded, and all the questions and comments would be recorded as well. The webinar attendee microphones have been muted to ensure optimal quality for all the participants. If you do have questions for the presenters, we urge that you use the question and answer tool in the Zoom platform, and our presenters will try to get to those questions either during or after their talks. If not, we can send them the questions on email, and they'll try to get to you there. As a reminder, the lectures are being recorded and posted on the APDR YouTube channel to be viewed on demand at any time for free. So please enjoy those at your leisure. Our two speakers for today, Tuesday, April 28th, are Dr. Gary Danton from the University of Miami. Dr. Danton is the Associate Professor of Clinical Radiology and the Program Director of the Radiology Residency in Miami. His topic is traumatic diaphragmatic injury. And we also have Dr. Adam Flanders from Jefferson University, Professor of Radiology and the Co-Director of Neuroradiology ENT. And Dr. Flanders at 12:30 will be speaking on spinal trauma, fact and fallacies. So without further ado, I'd like to welcome Dr. Danton from Miami. And I'll stop sharing my screen and ask if you could take over the presentation.
Hello, everybody. So I'm going to be talking about traumatic diaphragmatic injury. And I'm down in University of Miami and Jackson Memorial Hospital and Ryder Trauma Center. So we get a lot of trauma down south. And I hope all of you are doing well. Let me see if this can advance. Okay, no disclosures. All right, so what is really important about diaphragmatic injury in the setting of trauma? Well, the most important thing is that you look for them. And the reason that you have to look for them is because they are very easy to miss. So we're going to talk initially about the why, when, and how do you find a diaphragmatic injury. So why look for them? Well, you have to look for them, as I said, because they're hard to see. You have to look for them because if the patient is intubated and on a ventilator, the ventilator can trick you and hide them. And you need to look for them because they can have a delayed presentation. So if you miss them, the patient can show up 2 to 3 years later with strangulation from a diaphragmatic hernia, which carries a pretty significant mortality. So why else? Well, patients are more frequently being selected for non-operative management in the setting of trauma, but many of these patients will have an occult diaphragmatic injury. And the surgeon may opt for operative management if you detect that occult diaphragmatic injury. So there have been some studies that looked at diaphragmatic injury and shown that in patients who were initially non-operative but had significant enough trauma to become operative, about 20% had injury. Now, granted, if they went from non-operative to operative, they had significant trauma. But still, that's a fairly high percentage that actually had diaphragmatic injury. In patients with stab wounds, about 7% of stab wounds to the thoraco-abdominal region had diaphragmatic injuries, most of which are on the more commonly on the left side of the abdomen. About 17%, I think, were on the right side. So when do you look for them? You look for them in cases of severe blunt abdominal trauma and in cases of penetrating a trauma to that thoraco-abdominal region, where you have basically the nipple line to about L1. All right, now how do you find them? So the way I like to think about signs of diaphragmatic injury is I break it down into signs where the diaphragm itself is injured, signs, secondary type signs where you're looking at the herniation itself. So these are hernia related signs. And then you have signs where you're looking at the injury pattern. So for diaphragm injuries, you have segmental defects. So you actually see like a hole or defect in the diaphragm. You may see thickening of the diaphragm. And we'll show you the dangling diaphragm sign, where you kind of see the diaphragm just flopping around in the abdomen. Then your hernia-related signs include the collar sign, which is most commonly seen around the liver. For the collar sign, it's usually around hollow viscus, where the diaphragm is squeezing the viscus. And so you get this kind of collar appearance. Then there's the dependent viscera sign, which we'll talk about in a few slides. And then the hump sign and band sign are related to the liver. Then there's signs where you look at the injury. The contiguous injury sign, you're essentially looking for injury above and below the diaphragm. Now, this was classically described in the setting of penetrating trauma. So if you have injury above the diaphragm and you have injury below the diaphragm, well, there's a good bet that if there's one injury, that diaphragm is injured. And then you can do a tractography, which can be very complex or can be very simple, but it's essentially it essentially reflects the importance of following the trajectory of a projectile or a stab wound from its origin in the skin to where that ends up. And then if you follow that, you can look for injuries of multiple organs, including the diaphragm. So I'm going to talk a little bit about sensitivity, specificity. I'm not big on memorizing numbers. So if I say that something is high, I'm talking about like 75 to 90%. If I talk about low, 25 to 50%, very low, less than 25%. And we'll talk about that with respect to some of these signs. Okay, so now we're going to look at a few examples, and then we're going to look at a few cases. All right, so here's an example of a segmental defect. And I will say in most injuries, you're going to see multiple signs. But of course, you only need one necessarily. So if you look where the arrow is, you see a little bit of a thickened diaphragm over here, and then there's a defect in the diaphragm. So you have that hole, and we have some herniation of mesenteric fat. So that is a segmental defect. The dangling diaphragm is when you have a little bit of thickening of the diaphragm. It's usually around the crus, and here it is, and it just kind of hangs out, and you don't see continuity. So you usually have a segmental defect, but you kind of have a little piece of diaphragm dangling. The collar sign is when you have some viscus that is herniated through this defect in the diaphragm, and you have the squeezing of the viscus. Now the sensitivity is relatively low. You don't always see a herniation, but if you see it, you know that there's a very high chance that there's a diaphragm defect. The dependent viscera sign is a little tough. So ordinarily, you will have some lung interposed between the ribs and any abdominal contents. When you're high enough at that thoraco-abdominal region where you have the lungs showing on images. So here's an example of a normal. So this is how it should normally look. And then here again is the dependent viscera sign, where the viscera is just opposed to the ribs. So there are some findings that can confuse you. And they can be hiatal hernias, which can give you the appearance of an injury. You have Morgagni hernias. And if the patient is missing a spleen, sometimes it can look like you have a dependent viscera sign, even though it's really not. And this is normal up here on the top left. You have patients who have chronic diaphragmatic hernias. And so this patient has a huge hernia, but it was chronic, so they're not always traumatic. And then, of course, your classic botched-leg hernia. Okay, the hum sign and the band sign reflect the changes in the liver as the liver herniates up through the diaphragm. And the hum sign is just the appearance of the liver herniating up above the diaphragm, where you get this kind of big hump to it. The band sign is a little bit tough, and you really don't see it all that often, but when the liver is getting squeezed, you can have a change in the attenuation of the liver at the level where the diaphragm is squeezing it. It's kind of like a collar sign for the liver. And the hum sign, I would say, has a medium to good sensitivity. The band sign, the sensitivity is very low. For the contiguous injury sign, again, this was initially described in the setting of penetrating trauma, and it has a fairly high sensitivity, a surprisingly high sensitivity. If there is one penetrating injury, then it has a high specificity as well. But if you have multiple penetrating injuries, then you lose some specificity. So here you have a bullet tract through the soft tissues, and then you can actually follow it go between the ribs into the abdomen. You have some hematoma underneath the diaphragm, and so here you have a contiguous injury above and below the diaphragm, and the diaphragm was injured in this patient. Just one thing I'll mention about bullet injuries is, in the body, bullets do not travel in straight lines. They can curve within tissues. They can bounce off of bone. So you can't necessarily just look at the skin entrance and then where the bullet is and draw a line between them. You have to kind of follow bubbles of air and hematoma, look for fractures, look for subtle injuries to figure out the path. And this was really tough because it went straight down the skin and then hooked a turn into the diaphragm. So for trajectography, you do look at the origin of where the projectile went in, and you follow it to a structure, and then you follow it to the next structure. And you can do this using oblique MPRs, or you can just follow it along the path, looking at again, little bubbles of air and hematoma. Okay, so your sensitivity will be higher on left-sided injuries. It's harder to see injuries on the right side because of the liver. All right, so we're gonna go through some cases. So here's a patient with a gunshot wound, and it started in the chest, and you can see all of this contusion and hematoma, and it followed into the abdomen. And again, you can see, so you have a contiguous injury sign. Here you have that segmental defect. You have the mesentery herniating up, and you kind of create like a collar sign. It's usually used for hollow viscus, but I'm going to use it for the mesentery in this case. And then you have some diaphragmatic thickening. So all of these signs showing you that diaphragmatic injury. So, you know, the mesentery I'm counting as this organ for the sake of the collar sign. All right, next case, stab wound. So here you have some air within the subcutaneous tissues, and then we have a fracture. And look at this little fracture fragment off the rib has just barely penetrated the diaphragm. And so we have a segmental defect. You might say, who cares? It's so small. What difference does it make? Well, this was mentioned on the radiology report back in 2010, and this is what the patient looked like. And then the patient comes back a year later, and you can see there's no lung markings. It's an abdominal study, so I don't have the whole chest, but there's no lung markings here. this is all colon that had herniated through the diaphragm defect as it grew. So this is one important thing about diaphragm defects. They don't get smaller, they get bigger, they get worse. And that's why you have to find them. So he came in with a surgically confirmed colonic obstruction. All right, next case. Here's a patient with blunt trauma after a motor vehicle accident. Initially on the x-ray, we suspected a traumatic injury because the patient had some pretty significant blunt abdominal trauma. And let's take a look at some of the CT images. And so here you can see the viscous herniating through. Here's the diaphragm, right? So this gives you a dangling diaphragm sign. As the viscous kind of gets narrowed as it passes through here, that gives you a collar sign. The diaphragm is a bit thickened, and we can see the segmental defect. So here in this one image, or two images, you have the collar sign, the dangling diaphragm sign, thickening of the diaphragm, and your segmental defect, showing you this traumatic diaphragmatic injury. All right, we'll look at a case with multiple gunshot wounds. So again, with multiple gunshot wounds, the trajectory and the contiguous injury signs are going to be difficult to use because you don't know if one bullet went in the abdomen and one bullet went in the chest. So, but here on this image, here you have the stomach. So you have hollow viscous layering along the ribs. And so here you have the dependent viscera sign. So here you have air, here you have that hollow viscous. As we scroll down, dependent viscera sign. And then you get to see where the stomach is herniating through this defect. So we have a segmental injury and a pretty significant collar sign in the stomach. You can see how the stomach gets narrowed pretty significantly as you pass through the defect in the diaphragm. Okay. Next case, 82-year-old woman with presents with pain, which is the most common indication in our trauma center. They don't give you much history, and we see this large air-filled structure on the chest x-ray, and we're thinking, oh, traumatic diaphragm injury. And you get the CT scan, and okay, we're saying dependent viscera sign, so we're feeling pretty good. But then we notice that you see this beaking of the stomach going right through the esophageal hiatus. And you can follow it down, and turns out this is just a paraesophageal hernia. So the actual history was an 82-year-old who just slipped out of her wheelchair. So an example of how you can get fooled, and the history really helps you. And also looking to see where that hernia is coming from. All right, next case, you have a patient with blunt abdominal trauma. And as you're going through the coronals, you can see the liver pooching up above the diaphragm, right? This is our hump sign, maybe a collar sign. And this kind of pooching upwards is what you're looking for, again, with the hump sign. And you're really paying attention to patients who had pretty significant blunt abdominal trauma to give you a rupture on the right side. Next case, patient with a motorcycle accident. So we have bilateral pneumothoraces, lung contusions. We're going to have some hemothorax and some atelectasis. Okay. Again, We have our pneumothoraces, so we have some pretty significant trauma. And again, so we know we have trauma above the diaphragm, and we have trauma below the diaphragm, right? So we have some liver injury. Now, this isn't blunt abdominal trauma. And the contiguous injury sign, so injury above and below the diaphragm, was classically described in penetrating trauma. But we suspected, on the basis of these injuries and the accompanying fractures, that there may be a diaphragmatic injury. Difficult to call, but we suspected it. So they took the patient to the OR, and they ran the bowel, which was negative. They found some mesenteric hematoma, duodenal hematoma, but they did not check for a diaphragmatic injury. So this was the patient shortly after surgery. You can see all the lung injury, but the diaphragm looks pretty good. Patient, getting better. Everything looks fine. Patient intubated. And then what happened? So here is August 1st, and then on the left is August 2nd, so 1 day later. And something is different about these images. And if you look at the diaphragm, you'll see that the right diaphragm on the second is much more elevated when compared to the first. And so what's the difference? What happened? Well, he was extubated, tracheostomy. There's no longer positive pressure from the endotracheal tube. And he stayed that way, multiple x-rays. We just have this elevation appearance of the right diaphragm. Patient continued to feel a bit short of breath, and a chest x-ray kept noting this right basilar opacity, so they did a CT. You see the liver looks pretty high up, and then we'll take a look at the coronal. So nothing was noted, but the patient ended up coming back, and we'll see those images soon. So nothing was noted on this exam, which was a month later while the patient was still being treated. But you can see while they're intubated, here's where the position of the liver is, then extubated, look at that liver. That is a hump sign, right? Here's the liver, hump sign, okay? And here's 4 years later, all right? The exam from 2012 versus the exam from 2016. And it wasn't picked up, the difference wasn't picked up on those initial scans. It wasn't realized. And more of the liver, including some other organs, you can see were herniating gradually up into that right chest. And look at the size of this diaphragm defect. You have this huge segmental defect containing now not just liver, but viscous and mesentery as well. So again, diaphragm injuries get worse. They get bigger, you get more herniations. That's why you have to find them. All right, case 8. Patient has a history of an old traumatic diaphragm injury. This is a 90-year-old patient who was transferred to us. So not too surprising. She's got viscous and mesentery above the diaphragm. That was part of the history. That was from her prior injury, so we knew about that. You look on the sagittal, a lot of viscous above the diaphragm. So this was on the same day. So at 6:50 a.m., this is how her chest x-ray looked. And then by 8:10 a.m., looked much better, much better. Well, what happened? They didn't repair her diaphragmatic injury. What did they do? Well, they intubated her. So now you have positive pressure ventilation. So everything, I mean, she still has, some hernia. You can see the gastric decompression tube above the diaphragm. She's intubated. doesn't look too bad, right? 111, she's getting better from her more recent injury. 115, they started decreasing the positive pressure to get ready to extubate her. So they're weaning her off the vent. What's happening? Well, now you see the viscous coming back. Then finally, she's extubated. And look how high that diaphragmatic hernia is, right? You have the feeding tube in the stomach all the way filling that left side of the chest. So then they realized they needed to go in and repair that, which they did, and patient did fine. But now you have post-op repair. She's intubated. Everything looks good. The stomach was incarcerated, but everything else pulled successfully down into the abdomen. The defect in this patient was 20 by 15 centimeters. So pretty sizable defect. 1 week later, patient is extubated and everything stays down, which is good. Okay. So here's another next case with a gunshot wound where you have the help of using the trajectory and the contiguous injury sign to your advantage. So we know the patient was shot up here in the axilla, but you see the bullet below the abdomen. He was shot once. So pretty much had to go through the diaphragm. And if you follow the pathway of the lung contusions and the fractures, as you follow it down, you basically go right through the lung, through the abdomen, into the spleen, and you have to have injury to the diaphragm. So by using the trajectory, you can tell where the bullet has passed through, and that there must be a diaphragm injury. And you don't have to question it, because the surgeons need to go in and confirm it. They have to do surgery to figure out if there's a diaphragm injury and repair it. Case 10, stab wound. Here's another example. So you're going to use the trajectory, right? So here's the defect in the skin. Here's the defect, goes right up to that rib. You have still more air there. Another rib fragment. This is different from that last case that I showed you. So this is a similar case with a little fragment off of the rib showing you, in this case, where the defect is, which was probably made from the knife itself. And then you have this segmental defect of the diaphragm with herniation of fat through the diaphragm and under the rib. So in conclusion, I would say most important in your trauma patients is remember to look for these injuries. We went through a bunch of signs, and hopefully by practicing them a few times now, you'll remember them. You gotta look for the diaphragm injuries because they don't get better, they get worse. And the patients represent with complications up to a year, 2 years, even 3 years later. So with that, I'm going to turn it back to Harp so we can welcome the next speaker.
Hello, everybody. First, I want to thank Harp and the APDR for the invitation here. Did you notice there's 641 people watching this? This is pretty cool. This is the biggest audience I think I've ever had. So I want to continue the discussion about trauma, but I want to focus on the spine, and I particularly want to focus on MRI of the spine. So my whole talk here is about concepts and controversies, because, I've got an axe to grind here. So I have no disclosures, but this is what we want to kind of talk about, or this is what I would like to talk about now, is a little bit about why do we use MRI in spine trauma? are we using it correctly? Are there things that MRI is really good for? And so what are the controversial things about it? And we'll focus on spinal cord injury because obviously that's the most important reason why we do MRI and why it's good for the neurologic exam. So why do we do this stuff to begin with? You know, well, why use it in spinal cord injury? Well, it does offer the most comprehensive evaluation of injury and spinal cord injury because it depicts the soft tissue component. That's a thing that we can't see on radiography or on CT as well. There's a lot of centers where the clinical evaluation is not complete without an MRI study. That is, if there's a clinical deficit, and it's really kind of changed our focus from the spine to the spinal cord. And most people around the world would agree, do an MRI in the acute period for any patient with a persistent neurologic deficit, a real neurologic deficit, that is spinal cord dysfunction. So we're all familiar with these kind of algorithms, you know, that are out there. You know, there's this, you know, that a lot of papers have been written about this. What's the best approach for doing these sorts of things? And, you know, what, you know, follow this arrow if this happens, and do this if that happens. I don't really know if anybody follows any of these guidelines. A lot of hospitals have them. They have them in their pathways and guidelines in their hospitals, but a lot of it is just kind of done shooting from the hip. So the previous approach was, you know, we would do an emergent MRI for patients with post-traumatic myelopathy, not somebody who had a little bit of numbness in their finger after a car accident, but actually had true myelopathy, true dysfunction of the spinal cord. You know, for patients that are obtunded, they were not examinable. Some of them would get a cervical collar and then get re-examined. Sometimes in the old days, they used to do flexion extension, even in obtunded patients. That's pretty old school. And we've all heard about these prediction rules, like the Nexus, you know, the National Emergency X-ray Utilization Study from 2000, a lot of patients, 34,000 patients, and the Canadian Cervical Study Group had about 8,000 patients. And they all kind of came up with the same conclusions about, you know, when you should do any kind of imaging, including radiography for spine trauma. So according to the Nexus, low risk criteria, okay, C-spine radiography is indicated for trauma patients unless they exhibit all of the following criteria: no tenderness, no intoxication, normal alertness, normal focal deficit, no focal neurologic deficit, and no painful distracting injury. Well, I can tell you, here in good old Philadelphia, hardly anybody who comes in our emergency room meets this criteria, because, you know, people are doing this kind of stuff, acting a fool. By the way, this is from, you know, the good old Super Bowl win for the Philadelphia Eagles. And there were a lot of people doing this kind of activity. And I can guarantee you the mobs of people that you can see on the street, every one of them is intoxicated. So none of them would have fulfilled Nexus criteria. So if you look at the appropriate use criteria, they kind of mimic a lot what's written in the Canadian and Nexus rules to begin with. But they do agree you should do multi-detector CT with sagittal coronal reconstructions. It's the best screening procedure right now in adults with high risk criteria. The entire spine should be examined with CT, and you can even derive them from thoracic, lumbar, and pelvic CT, so you don't have to rescan people. Radiography is still the imaging method of choice in children, and flexion extension radiography is a waste of time. So our surgical colleagues, the Eastern Association for Surgery and Trauma, they recommend that they say there's just 4 categories of spine trauma patients. There's the alert, awake, non-intoxicated, normal neuro. They don't occur, certainly don't occur here in southeastern Pennsylvania. We have patients who are alert, awake, complain of neck pain, and we have patients with neurologic deficits that might be related to spine trauma. And then there's a 4th category, alert, mental status obtunded, and may return to normal mental status not anticipated for greater than 2 days. And really, out of those 4 categories, the only one that they actually recommend that you should do MRI on is number 3, neurologic deficits related to spinal cord injury, not even for number 4. So what are we talking about here? We're talking about an awake patient versus an obtunded patient. The first patient you're looking at here, this person has been in a car accident, but he's alert, he can follow commands, he can answer questions. This patient cannot. Should we be using MRI for the second patient? Does that answer all the things we need to know? Because we can't do a good physical examination on these folks. So, the conditional recommendations are in obtunded adult plyometricians patients, they conditionally recommend taking off a cervical collar after a negative CT exam, but don't recommend doing an MRI. So I can tell you, so why do we do MRI, and why does it seem like we seem to do a lot more MRI than we've ever done before? What's really the problem here? What's going on, or is there a problem? Well, if you look at some of the CMS data right now for outpatient utilization for MRIs across the country, you can see it's kind of flattened out. If you look at inpatient utilization, it's kind of decreased and flattened out. But if you look at utilization of MRI in the emergency room setting, it has continued to rise over the last 12 years, almost to the tune of 4 times. And these are the things that, you know, the Deficit Reduction Act, these are the things that has put radiology in the crosshair with PAMA and so forth. People are looking at us and saying, hey man, what are you guys doing about this overutilization without any potentially a proven benefit in the literature? So I want to focus a little bit about this. So does MRI provide any complementary or supplemental information in spinal injury? And I want to kind of go through the spectrum of injuries that exist out there, what's true and might not be true about all of this. And recognizing that this was kind of a broad spectrum of injuries, the most important thing that we can see, and the only modality where we can actually see a spinal cord injury on imaging, is on MRI. So for fractures, it's really not the most cost-effective way for looking for fractures. We know CT is so much better for this, and yet people still, and sometimes in the reports, and I certainly tell the residents frequently, your pertinent negative in reading an MRI is not to say no fracture or no evidence of fracture is seen. That's not what we do it for. But certainly if you have a rip-roaring fracture like this L5 burst fracture where you can see disruption of the superior end plates, you know, yeah, you can see it. But I guarantee you a 25-cent radiograph might have shown you the exact same thing. And granted, while you can see the fracture line, the split sagittal fracture in the cervical vertebra here, you cannot see the fractures of the posterior elements at all on MRI. So it's, in fact, MRI is notoriously bad for looking at posterior element fractures. But what MRI really shines about is for compressive injuries, you know, compressive marrow injuries to the trabecula where there's been axial loading to the bone. These are things that you may not see. They're relatively subtle on CT, but they show up really great on MRI. And you get this characteristic low signal on T1, hyperintensity on T2. You may not be treating any of this because there may not be mechanical failure of the vertebral body, but you can certainly see that there's been multiple axial loading injuries to multiple adjacent vertebral bodies in addition to this burst injury here at L1. How about here? This is a young woman that was in a motor vehicle accident, has searing neck pain, and sure enough, she has these striations in her vertebral bodies from a hyperflexion type injury. More to come. So this is one of those things, an added benefit we get with MRI, and certainly for all the people that we see that have osteopenia, osteoporosis, develop multiple insufficiency fractures over time. MRI will show you the acute fracture here. You'll see it healed 3 months later. Meanwhile, 2 more fractures have developed, and you can see them. You can see them great because you can see the reversion of the marrow changes going on and so forth. So I'd say, you know, MRI has some supplemental benefit for fractures, but it's not really the primary reason why we do MRI to begin with. And we know disc herniation is the prototypical, you know, soft tissue abnormality that we see, and that's what MRI is really designed to detect, and it really kind of exceeds all other abnormalities. And the incidence of disc injury is relatively high in high-speed motor vehicle accidents, but not necessarily traumatic disc herniations as often. And so here's an example of someone with a disc herniation with some epidural hematoma. You can see the disc herniation really nicely on the MRI, and you know, it kind of stands out against the hematoma, but this one's where it's so large that you can actually see it even on the good old-fashioned CT scan. But this is what I mean by disc injury. This is somebody who had a hyperextension type injury, widening, an open book type of injury to this C5-6 interspace. And what ends up happening is you end up macerating the disc, and the disc, the lacerations inside the disc, if you will, fill with fluid, and that disc ends up being brighter than any of the other ones. So if you see somebody with a really degenerated spine who's had trauma and one of the discs is brighter than all the others, take a little time to scrutinize it a little bit because it might have been injured at that level. If you have a CT, go back and look at the CT again and see, could you see a little avulsion of an end plate? Can you know, is there a little bit of soft tissue edema? This one is not too hard to see. This big prevertebral injury here in the front in this other case that also has a hyperextension injury. So I think it's fair to say MRI's got a lot of value for traumatic injury of the disc and disc herniation. How about for looking at vascular injury, vertebral artery injury? It actually occurs relatively frequent, with a fair amount of frequency in cervical injury. And back in the day, you could say, well, if you're doing MRI anyhow, you could just do an MRA as well to see if somebody lost their vertebral artery. Here's somebody who has a flexion teardrop fracture of C5, a bad spinal cord injury, and whoops, lo and behold, lost their dear friend, Mr. Right vertebral artery in cross section on the axial T2s. You can see a nice flow void on the left. On the right, we've got light bulb on, light bulb off. This is clot sitting in the foramen transversarium. And there's been some series written about this that say it's actually more frequent than you might think. This is a whole series of over 600 patients, just spinal injured and spinal cord injured patients, finding that losing a vertebral artery could happen more often when you had spinal cord injury, but in patients that that had minor injuries, or even patients that had no injury at all, 11% of them lost a vertebral artery, but had no clinical consequences of it. So the moral of the story was absence of a spinal cord injury does not exclude loss of vertebral artery. The best way to evaluate for this, there has been a debate. There was previously a debate: is CTA better than MRA? Is MRA better because, you know, or black blood techniques? But the fact of the matter is everybody's favorite toy in the emergency departments today is CTA. So I'd say, you know, CTA is getting done with much more frequency than MRA or black blood techniques, just because of the era of convenience, and everybody is used to doing it. The consequences of this is up in the air. There's been some literature that say up to half of the patients that lose a vertebral artery as a result of trauma will suffer a serious posterior circulation stroke. But the lower limit of this is less than 1%. So it's hard to know. It really depends on what series you're looking at and who you've been talking to. Here's an example of someone. This is an unfortunate father who was trying to teach his son how to skateboard, and you can see this dislocation here at C23. This is one of the worst I've ever seen. So here's the dislocation at C23, a lot of prevertebral edema here. If you look in cross-section on the T2s, 2 light bulbs here, both vertebral arteries are clotted off here from this dislocation. They relocated him in the operating theater. You could see the edema in the spinal cord took off. And of course, he was already a high cervical injury. He then became obtunded. And when you look here on the CTA that was done afterwards, there's a clot floating inside of his right vertebral artery. So basically, restoring alignment to the spine, restored flow in the vertebral arteries. There was clot in the vertebral arteries, and it sent it skyward up into the brain. And unfortunately, he did not survive. So the value for MRI for detecting clinically significant vascular injury and spine trauma is probably pretty good, but probably not used as much. Up to 40% of patients will have extraaxial epidural hematomas associated with their spine trauma. Most of the time, particularly because the epidural space is freely communicating, the hematoma will disperse itself up and down longitudinally in the spinal canal, and you don't see a whole lot of consequence as a result. But loculations can lead to focal compression. Here's a few examples of here's somebody with ankylosing spondylitis with a huge posterior epidural hematoma. Here's somebody who was on anticoagulation who fell and had a big posterior epidural hematoma and also a fluid collection. And here's just a garden variety fall with a huge hematoma ventrally from the thoracolumbar junction on down. This patient had no consequences neurologically. Here's another patient with no consequences neurologically because the cauda equina is extremely tolerant to compression. So here's a very long hematoma running the full length of the lumbar spinal canal, causing compression of the thecal sac with no issues. Here's another patient with a large loculated hematoma in the posterior epidural space of the cervical canal, which you can almost see better on the CT than you can on the MRI. Interestingly enough, here on the cross section on the CT, it shows up a lot better. This patient required urgent decompression because it was mash in the spinal cord. Here's another focal one that did not track up and down very well, compress the spinal cord, also required evacuation. Speaking of fluid collections, one of the other things you can see after trauma, particularly after traction injuries, is that you can get nerve root avulsions, and you'll see one of the things to look for in heavily T2 weighted sequences is epidural fluid elevating the dura away from the ligamentum flavum or the bony landmarks, because this may imply that there's been a root avulsion or a tear to the dura that's actually causing the CSF to leak out. And here's a nice nerve root avulsion here of C6. So MRI is pretty good for, this is pretty the sine qua non for looking for traumatic epidural connections. So this is what I want to spend some time on, because this is where I got some beefs. Ligamentous disruption on MRI. And so let's spend a little time about this. And I think it's true, MRI is probably the only modality that really demonstrates either discontinuity of the ligament, fissuring of the ligament, or maybe edema of the tissues around the ligament. But the real question is this thing down here. When does it meet what we see? When does it actually reflect spinal instability, either acute or delay, and when is fixation required? So when you see something like this, where you see the split end of the ligamentum flavum right out here in front of the spinous process, you're right, this is a torn ligamentum flavum. I agree, we can see it, you know, and it may be helpful, and you can see all the edema in the posterior paraspinal muscles. What does this mean regarding treatment? Here's an even crazier case, but you could see this on a 25-cent lateral radiograph, someone with a cervical thoracic dislocation, where you can see the free edges of the anterior longitudinal ligament and the torn edges of the annulus fibrosus dangling in the breeze, as well as the ligamentum flavum floating around back here. Everybody knows this is an unstable injury, but you'd know it was an unstable injury from a cervical radiograph. Here's an unfortunate kid who was injured during a wrestling practice with a dislocation at C3-4, a big dollop of disc material compressing the spinal cord ventrally, the whole posterior ligamentous complex disrupted posteriorly, but the angulation and everything that you could see here on a lateral radiograph would tell you that this is bad news. And here's another example of somebody with a unilateral interfacetal dislocation, which is supposed to be the mechanism of injury is not only hyperflexion, but it's also rotation. And MRI is helpful in showing us, and also the disc is destroyed because you rotate one vertebral body on top of the other. So the disc loses its own integrity. And you can see all of those features are represented. Here's your jump facet. Here's the inverted hamburger here on the right side here for those that believe in hamburgers. And here's the disruption of the posterior ligament, the posterior soft tissues, and there's the damaged disc, some of it leaking out here in the front. So all of that is proven. Here's someone again with a big dislocation at the thoracolumbar junction, an oldie but a goodie. This hand has all the free edges of all of the structures, the ALL, the inner and outer fibers of the annulus, all just dangling in the breeze, and the horribly compressed thecal sac and spinal cord. Here's just yet one more extension type injury here, a double extension type injury where the fissuring of the disc occurs, but undoubtedly the anterior longitudinal ligament is split here as well, because there's just a big wide gap here and a lot of prevertebral fluid. So what does this mean in terms of instability? So what are the significance of soft tissue? And so here's your 25-cent lateral radiograph, and what's going on with this patient here. And the hint is, of course, this patient is a little bit taller today than he was yesterday, because his head is actually floating way above C1 and C2. And this is a guy with a complete craniocervical disassociation. Do you need an MRI for something like this? You know, it's pretty clear on the X-ray and then on the CT that there's, 8 feet of space between the head and the neck. Probably not. This is really great for demonstrating the total circumferential disruption of the soft tissues that you'd expect anyhow with MRI. Here's that woman we saw before who had the searing neck pain. Remember, we were talking about the striations of her vertebral body from axial loading, but look what's happened to her posterior soft tissues. This is not bad fat suppression. This is signal in the back of her interspinous ligaments. So what does this actually mean in terms of ligamentous instability? Does this mean this patient needs to get 8 feet of titanium put inside of her neck, or is this something that will heal on its own? Here's one of those classics that people ask about. Like Harp was asking me about one of these just the other day. Here's a rotatory injury of C1-2. There's a patient who could not straighten his neck out after an injury at a basketball game, clearly has asymmetry in his dens. Figure this is a classic soft tissue injury that can be solved with MRI. Hyper-rotated between C1-2, rotatory subluxation, C1-2. MRI is clearly going to be horrible. And sure enough, we do the MRI and the ligaments are really quiet. There's not much going on here at all. So MRI seems to have let us down. And here's an example, of course, where MRI is really helpful, although I would advocate you could actually figure this all out on a CT scan. This is a patient who got drunk, fell down a flight of stairs while walking home, started getting weak, woke up the next day and he was paraplegic. And all of his studies were read as normal. But the important thing is, and this is what I always advocate to everyone I know, don't forget to check the soft tissues on your CT scan. If you look at the soft tissues, there's all kinds of trouble going on back here. You don't see any of the normal striation of muscle or any of the fat and tissue planes very well here, because there's been a horrible soft tissue injury here. So this patient has had a pure hyperflexion, a non-osseous hyperflexion injury, an unstable hyperflexion injury, and he was actually banging into his spinal cord when he was walking home because he was just subluxing while he was walking. But you can see all the disruption posterior here, interspinous ligament, and even the intervertebral disc space didn't affect any of the bones at all. So always check the bones. Is there surgical proof for this? Well, there's been a series of articles. This one was touted for a number of years, but this one would kind of, which I'd say has fallen out of favor for things like this, where they did actually a little more, I would say a little more aggressive evaluation. In this case, cervical MRI findings of ligamentous injury in a small group of patients, multiple readers, then checked to see if the ligaments were messed up in the operating room. And what they found was agreement between readers was very low and inconsistent, which was problematic, even though they thought they were seeing things. But their conclusion was, based on results, some caution should be used in relying on MRI for preoperative planning, as it can falsely overestimate the degree of soft tissue injury. And there's a lot of studies out there that would say, that is probably true, that you don't need to do MRI for this kind of stuff. Here's a prospective study, 100 whiplash patients scanned at 1.5 Tesla 48 hours after MVA, looking to see if you could find abnormalities in these proven clinically whiplash patients from other patients, normal controls and whatever else. And their conclusion was, in all but the most severe grades, MRI findings were similar in both groups of patients. So we didn't write a lot of this literature that says MRI, it may not be helpful. Here's one from Archives of Surgery. Over close to 3,000 patients, 100 of the patients had cervical injuries. And what they say is that the sensitivity of multi-detector CT for important findings, 99%, specificity, 100%, risk of missing an injury, 0.04%. It's pretty, it's pretty daunting. Multi-detector CT is really, really good. And their conclusion was that you do not need anything else after you get a normal CT result. And there's more. Here's Journal of Trauma, 2007. Blunt trauma patients receiving MRI. 6 of the patients uncovered occult injuries like microfractures, interspinous ligamentous injury, cord signal abnormality, and even epidural hematomas. But yet none of these findings changed management or even required use of a cervical collar. And yet 6 of those patients had cervical collar complications. So their conclusion was, hey, MRI could be completely unnecessary if a CT is negative, and it can decrease costs and lead to early collar removal. And the real stinking truth here is that these fashion accessories are not so benign after all. There's a whole body of literature that says this causes skin ulceration, maceration, decubiti, exacerbates intracranial hypertension, interferes with swallowing mechanisms, creates difficulty with intubation. When we say there's something wrong in somebody's neck, it could potentially keep somebody in a collar longer, keep somebody in a unit longer, or whatever else. And people have worked this out. They've worked out the economics, and have basically said early collar removal and foregoing an MRI can offer the lowest risk strategy for comatose patients with a negative CT and no positive, although I don't know how they figured out the positive neurologic findings if the patient is already comatose. But people have already figured out it can cost a lot of money just to detect an occult instability, and 1 in 1,000 patient can cost several $1 million to begin with. There's hidden costs for keeping people on a ventilator in an ICU when they may not need to, because they're waiting for an MRI for some kind of clearance or whatever else. And so basically, this was one of the best articles ever done. This one was done Journal of Neurosurgery, 14,000 meta-analysis from 17 studies basically said sensitivity and specificity for multi-detector CT exceeded 99.9% overall, and there was no validated path description for acute unstable injury in the absence of bony injury and neurologic correlates. So they concluded, strongly suggests you can remove a collar in a obtunded or intubated patient if the MDCT is negative. They predicted 1 false negative multi-detector CT study every 14 years in a typical trauma center, compared to up to 67% of cervical collar complication rates. So during those same 14 years, up to 32 patients could have a complication just from prolonged use of a cervical collar. So that's really the dilemma. Up to 25% of all comers will have soft tissue abnormalities on their MRI, and we don't really know how to equate that with instability and management decisions. So we should always approach that with a little bit of caution. So while it could be great, it can also be fraught with problems. So I just want to spend the last couple of minutes talking about spinal cord injury and what we use MRI for that. Injuries is still a big problem in the United States, still peaks in the summers and weekends, although with the advent of really good quality safety harnesses and airbags and so forth, a lot of this has decreased, but it's still, US expenditure is about $6 billion a year. Things have changed for spinal cord injury in contact sports specifically because there was a decrease in head injuries in the 1970s theoretically due to better head care, but there was a sharp rise in spinal trauma. And we break these up into transection type injuries where the cord actually splits in half, which is relatively rare. Here's a transection in the thoracic spine, and here's a spondylopsis from a motorcycle accident. Obviously, you don't need an MRI for this, the 25-cent radiograph, and here's a stab wound to the cervical spine. It still gives me chills just to look at that. And then there's concussive injuries that can happen from a bullet passing it through or nearby the spine that can cause edema inside the spinal cord. But the main thing to know about this is that for blunt trauma to the spinal cord, portions of the architecture are salvageable, so this is why Big Pharma is very interested in this. And the three features to see are swelling, edema, and hemorrhage. The edema is proportional to neurologic deficit and prognosis, and hemorrhage is usually associated with the most severe injuries and predicts the greatest or the poorest neurologic recovery. And here's just an example of edema on some sagittal long TR sequences on a unilateral facet dislocation. Here's a potpourri of edema, hyperintense, flame-shaped area spanning the length of the spinal cord. Compare that to hemorrhagic spinal cord injury, which is dark on gradient echo and T2-weighted images and has the worst prognosis. Here's a thoracic example and another potpourri and a stab wound. There's also a scoring mechanism that was developed by Jason Talbot at UCSF for scoring the severity of spinal cord injury, graded 0 to 4, called the BASIC score, which I invite you to look at this reference for. And essentially, those are the features of MRI: the length and location of hemorrhage and edema inside the spinal cord, the cross-sectional extent, the extent of compression, and so forth. This has high value in evaluating spinal cord injury because there is no other correlate to this. And with that, it's top of the hour. I'm going to finish up there, and thanks a lot.